All right, let's look beyond the scalpel for a second. We're diving into this explainer to uncover the massive, complex web of data, ethics, and protocols that actually keep a surgical patient safe. We almost always picture the bright lights of the OR and the steady hands of the surgeon. But the reality? The true foundation of a safe surgery is built long before that first incision is ever made. Today, we're unpacking the hidden architecture of surgical practice. So we're going to break this down into four main pillars today. We'll start with the data behind the scalpel, move into patient autonomy and consent, then look at how we prevent absolute surgical disasters, and finally, wrap up with real-time pathology decisions.
Okay, kicking things off with Section 1, the data behind the scalpel. This is all about epidemiology in surgery.
Before a surgeon ever even steps into the OR, they're relying on population data to predict risk. Think of it like this. If researchers want to link a risk factor to a disease, they basically have two ways to do it. They can look forward in time, that's a cohort study, starting with an exposure to find the relative risk. Or they can hit rewind. They look backward with a case control study, starting with people who already have the disease to figure out the odds ratio of something they were exposed to in the past. Now, what we get from these studies are some absolutely crucial metrics. Let's start with incidence. I want you to think of incidence as literally the velocity of new cases just popping up in a population. It doesn't care at all about folks who got sick 10 years ago. It only measures the speed of newly diagnosed cases right this second. It's a pure, strict measure of a disease's current momentum. But, how does that velocity translate into the bigger picture? Well, that is where prevalence comes in. Prevalence is a static total. It captures everyone at a single snapshot in time. Basically, it's just the incidence multiplied by how long the disease actually lasts. So if a disease spreads like wildfire but cures quickly, your incidence spikes, but prevalence drops right back down. But if it's a chronic issue, that prevalence just keeps building and building. So here's a really practical, kind of mind-bending challenge for researchers. What if you're trying to track a cancer that is so incredibly rare, like, say, pseudomyxoma peritonei, which comes from the appendix, that doing a forward-looking cohort study would literally take lifetimes? I mean, if you just waited around for healthy people to develop it, you'd be waiting forever. Well, the answer is this incredibly elegant statistical workaround. Since the disease is just that rare, you start by gathering the few known patients who already have it. You use a retrospective case control study and look backward into their history to calculate that odds ratio we talked about earlier. It's brilliant, really, because it lets medical science understand these rare diseases without needing centuries of follow-up. Moving right along to Section 2, autonomy and informed consent. This is all about the patient's ultimate choice. Because look, no matter what the population stats say is the absolute best medical choice, all that data eventually slams right into human free will. Imagine this crazy high-stakes scenario. You've got a mentally competent adult with advanced diabetes, and they flat out refuse a life-saving amputation. Meanwhile, a desperate relative is begging the surgeon to override them. The surgeon knows, with 100% medical certainty, that this patient will not survive without the surgery. So, what is the ethical move here? Well, the rule of patient autonomy is absolute. Step 1, the surgeon has to sit down and provide completely objective, comprehensive counseling about the grim reality of refusing the procedure. If the patient totally understands and still says no, step 2 is deferring the surgery. A family member absolutely cannot override a competent adult, period. And then, step 3, which is crucial, meticulously document the whole shebang. And that brings us to a fascinating reality about legal protection in medicine. A standard, generic signed form? Yeah, that's not going to cut it. The real legal armor, the true documentation defense, lies in customized clinical notes. It proves the surgeon didn't just shove a piece of paper across a desk, but actually had a deeply personalized, specific conversation about that individual patient's risks. All right, let's jump into Section 3, preventing surgical disasters and the system safety nets we rely on. Human error is basically inevitable, right? So hospitals build these massively complex layers of defense, kind of like slices of Swiss cheese, to catch mistakes. And how we categorize those mistakes is really important. A near miss means our safety nets worked, or honestly, we just got lucky. The error was intercepted before it ever touched the patient. But an adverse event? That means the mistake actually reached the patient and caused documented harm directly from the medical management itself. But then you have what's called a sentinel event. And this is vastly more catastrophic. If one of these happens, it demands an immediate root cause analysis, because it means the very systems built to protect people completely failed. A sentinel event involves death or severe, permanent harm that has absolutely nothing to do with why the patient was in the hospital to begin with. It is a massive, glaring red flag that the safety protocols are structurally broken. And the examples are genuinely shocking. These are exactly the nightmares hospitals are desperately trying to prevent. We're talking about leaving a surgical sponge inside a patient, or operating on the wrong leg, or giving a patient an ABO-incompatible blood transfusion, literally the completely wrong blood type. They sound totally unbelievable, but these are classic sentinel events. And when they happen, hospitals are forced to completely rewrite their protocols so that specific failure can literally never happen again. Which brings us to our final section, Section 4, Real-Time Pathology. We're talking about making decisions on the fly. So we've talked about big data and system safety, but let's zoom right into the operating room, where these high-pressure, real-time cellular decisions are happening while the patient is fast asleep. When a surgeon removes tissue, they might temporarily toss it in some refrigerated saline just to keep it from drying out. But what they really rapidly need is 10% formalin. That's the gold standard. Formalin cross-links the amino acids and essentially locks the cellular architecture perfectly in place so pathologists can study it safely. But what if you literally don't have hours or days for that formaldehyde to do its thing? Imagine a surgeon is removing a tumor, and they need to know, right in that exact moment, if the edges of the removed tissue are clear of cancer cells. The clock is ticking, right? The patient is still under anesthesia, and the surgeon's very next move depends entirely on knowing the cellular reality right then and there. So what do? They use a frozen section. This is a brilliant workaround that gives you rapid answers in mere minutes, but man, it comes with some severe trade-offs. The lab rapidly freezes the fresh tissue, but doing that creates these tiny ice crystal artifacts that totally distort the view under the microscope. You get inferior architectural quality, making it really unreliable for detailed tumor grading. Plus, without the formalin, you're exposing the lab staff to a much higher infection risk. It's essentially a high-stakes, calculated gamble for speed. And I think that leaves us with a really fascinating final thought for this explainer. In medicine, just like in life, every single decision is a calculated trade-off. We saw it when we looked at studying rare diseases with odds ratios, and we see it right here in the OR, accepting distorted ice crystals just to get a rapid, life-saving answer. It kind of makes you wonder, knowing these precise trade-offs, where else in our critical systems are we sacrificing perfect architecture just to get a rapid answer? Thanks for joining me on this explainer today, and keep questioning the systems around you.